Hello, everybody. I'm Gary Goldenberg, dermatologist in New York City, and welcome to another exciting Conversations in Aesthetics podcast. I am so happy about our guest today. Dr. Cheri Frey is a friend. She's a dermatologist, an amazing public speaker, and really a master of a wide variety of dermatologic conditions and treatments. Cheri, thank you so much for being here and welcome to the podcast.
Thank you so much for having me. I'm excited.
It's going to be a good one. I can feel it already. So we're going to start off with just an easy one for you, Cheri. Why don't you tell the folks who you are, where you practice, your likes, dislikes, I know you've had a long career in private practice and academia, so why don't you tell us all about it?
Yeah, I practice in Washington, D.C. It's really a diverse population. I was born and raised here, so it means a lot to come back and serve the community where I grew up. I'm currently at Howard University, and so I do have both teaching and research capacities there at Howard. I'm the residency program director, so I'm responsible for selecting and training the next generation of dermatologists, which keeps me very busy. And I do a lot of work in our clinical trials unit for the hospital. I'm the medical director of the clinical trials unit. I love all things dermatology. I think, like so many of my colleagues, that is what was so attractive about the field, being able to, see patients longitudinally, but take care of aesthetic concerns, medical concerns, surgical concerns, and then, of course, the pathologic component to it as well with DermPath. So it's really exciting. There's so much innovation in dermatology. I'm not bored yet. I hope you're not bored yet.
Never. No, I think what you just described makes me want to go through dermatology training again if I wasn't already in it. We really are very lucky. We have a great specialty, but we are going to focus on aesthetics. I know you have an aesthetic component to your practice as well as a medical. You're gonna leave your medical hat off unless you want to bring something in the conversation, but really focus on your aesthetic hat. So I want to just kind of get a sense of the patients that you see, the procedures that you do in your aesthetic office, and what's that conversation? Somebody comes in, and you say, well, tell me what you don't like about yourself. What's that conversation like?
Yeah, this is something that, I think when you say leave the medical hat off, yes, from sort of a prescription standpoint, but I think that's really what sets us apart when we treat patients, even for their aesthetic concerns, is having a deeper understanding of the skin and the scientific foundation of all of the procedures that we provide. So I'm a nerd even when I'm performing cosmetic procedures. And we do a wide range of treatments. I really love treating sort of medical conditions with aesthetic devices. I think that there is a huge overlap, and unfortunately, for a lot of patients, the sequela of our medical conditions, it could be erythema, hyperpigmentation. And so, even if it started off as a medical condition, it can transform into a cosmetic concern. And so, we have energy-based devices, often using skincare or, cosmeceuticals, as it's come to be known, to help improve the appearance of dark spots or post-inflammatory erythema, scarring, hair loss. So, there are a wide range of treatments that we offer our patients.
So I love using devices for medical conditions, and for me, acne is probably the one where I am more device driven now than I am RX driven because the devices have gotten so much better. So I love the fact that you're kind of thinking the same way. And I think there is a spectrum where sort of the medical runs into the aesthetic and vice versa. Somebody can come in because they don't like the way something looks and it's a basal cell, or they have acne, they develop scarring, pigmentation, erythema, and you kind of able to address it. I love how you kind of categorize that. So somebody comes in, what do you think is like a successful aesthetic consultation? I always ask my guests how they approach patients when they talk about aesthetics because it is a different approach. They're more of a client than they are a patient because it's a cash pay versus a third party pay. So it's a little bit of a different mentality. So what's that like for you when you talk to your folks about, doing aesthetics? What's a consult like?
Yeah, the consult is a key component of what we do, right? Because you have to understand what the patient's goals are. So much of what we do in the consultation is helping the patients differentiate, fantasy from reality and helping them understand why we use the procedures that we use, what the expectations are as far as what success looks like, because what success looks like to the patient may be very different from what we would interpret as a successful outcome. And so I think you have to be very realistic with the patients about what their goals are and what we're able to achieve. And then you also have to set some expectations. Is it just one treatment, for instance, that could, get them to that point? Or are we going to need a series of treatments? Is it one device? Are we going to have to use more than one device to treat the patient? How much is it going to cost? And you don't want a patient to start that journey and then find out halfway through that they're not able to complete it because of, financial constraints. So I think the consult is a key component of the aesthetic treatment. You also need to understand the patient's background. We are a mixed salad of races and ethnicities. And often what we see on the surface does not tell the story of, the patient's heritage. And because we're using energy-based devices, we need to know those things. And we need to know, what's going on in their life. Do they have a wedding? Are they planning a vacation in 2 weeks? Are they going to some place that's really, really sunny? And so we need to work around that. And so often the patient doesn't know components of their medical history that may come into play for the devices or the treatments that you're using. So you really do need to take your time, and it should be comprehensive. And I charge for my cosmetic consultations. I know people go back and forth about that, but it really is a intense and thorough visit, and it's not covered by insurance. And so we do need to make sure that we are being paid for our expertise and our time.
So there's so many great nuggets from what you just said that I want to kind of tease out, if I may. So one is I always want to talk to folks about how they define success. So you're seeing somebody, you're gonna do a procedure. What does success look like to you? Like what is a good outcome for you versus what the patients, may think or want?
Yeah, and that's going to depend on what our goal is. If I'm treating someone with psoriasis, I have a lot of data that demonstrates across a lot of races, gender, that we can achieve, for the most part, 90, sometimes even 100% clearance. We have good, reliable data. But when it comes to aesthetics, we're basing our perception off of our experience and smaller numbers of reported outcomes, right? And so it sucks to say, but results may vary, right? And so I think we can give them a window. We can give them sort of a target, but it is so important because people are reaching in their pockets to pull out money that they could be using for other things, that we help them understand. And so if I am recommending, a treatment, I said, okay, we're going to need 3 to 6 treatments. At the end of 6 treatments, my goal is to get you, you know, 50 to 60% improvement. And that may look like, and what is improvement, right? So if we're talking about scars, your scars would be 50 to 60% lighter in color. Or if we're talking about, rolling scars or boxcar scars, 50 to 60% more shallow than they were before. So we really have to kind of tease that out. And I think now that we're in the sort of AI and technology phase, a lot of us have devices that can sort of capture images and help to quantify it. I think that's better. And I like to stop midway, because if we're not, if I say 3 to 6 treatments and you've had 4 treatments and we've had 10% improvement, then we need to have a discussion about
Mm-hmm.
whether or
A
not
100%
we want to
agreed.
continue.
I just saw a patient who was treating red scars after a plastic surgery procedure. And I saw her once for consultation maybe 2 years ago, and then she went somewhere else because of convenience for some laser. She had over 20 lasers without improvement. And I said, whoa, whoa, like, when do you back up, take a step back and say, clearly this is not working because nothing works for everybody. So I think setting expectations is so important. I always talk to patients like there's a bell curve of distribution of success. Most people are in the meaty part of the curve, and then there's some where it's like, wow, I can't believe how good this result is, and then there's some where it's underwhelming, and you can't tell by looking at somebody. You can't predict
Right.
100% how they're going to do. That's the art of medicine versus the science of medicine. So I think that really hits home, and I love how you frame that. Something else that you said, which I think is so interesting, is about different skin types, and you can't always guess based on the way somebody looks how they're going to do. So I had a patient last year I treated with a CO2 laser, and he looked like me. He was identified as Caucasian. I wasn't worried about pigmentation, and he developed post-inflammatory pigmentation. And I talked to him. It turns out almost 5% of his genetic makeup, because he did like 23andMe, one of those things, was North African. I said, well, I wish I knew this before because I would have put you on hydroquinone prior, and then after the CO2, that we would have avoided this situation. So I think that's a good nugget that a lot of people don't actually think about. They just go by morphology as opposed to, genealogy, what actually, the mix that
Yes.
people have.
Yes, and you can do that. There was a publication where you can take a look at their palms and it divides them into, low risk or high risk based on the, intensity of the pigmentation within your palmar lines. And so that's a good general guideline. And you'd be surprised when you look at people and you have them ask them to put their palms up. What do those lines look like? So I think that's one way. But again, now that we're in, AI and tech phase, 23andMe, we're learning more about our genetics. I think we have more information, but it's sort of the same thing with Fitzpatrick skin types, where we're not really asking the questions. We're just using it as a proxy for skin tone. And that is a no-no when we're talking about energy-based devices or aesthetic procedures. It can get you into trouble.
Yeah, I agree with you 100%. So now I put everyone on Kligman's formula after I do something like CO2 or sometimes before, just to kind of get their skin primed and then keep it going. But that has a little hydroquinone just in case, they're going to develop pigmentation. So I love that aspect of conversation. Now, let me ask you, in your practice, if somebody's going to come in for an energy-based device, and I know we're going to show video shortly, um, is there a cutoff, pigmentary cutoff, where you say, okay, you know what, your skin is too high risk for me to do CO2, microneedling, fractionated laser? How do you approach that?
So I don't have a cutoff based on skin type or skin tone. Here's where that medical aspect and really having a knowledge of the device, but also just the basic biology of skin. Um, I don't have it, and I don't feel like my most challenging cases fall into the extremes, right? So skin type 1, skin type 6. I don't feel like we get into trouble there. We really get into trouble in skin types, 3 and 4, where people tend to be a little bit more aggressive than they should, especially with skin type 3. And I do see that with skin type 4, but I don't have a cutoff. I modify my parameters. I'll change my depth. I'll change, the coag. I'll change the density of the area I'm treating. But I don't have a strict cutoff. And I know a lot of people are concerned about hyperpigmentation, and you should be. But I think about all the different treatment options we have to prevent and to treat hyperpigmentation. I get more concerned about hypopigmentation because if somebody is
Agreed 100%.
depigmented, where am I going to get
100%
those
agree.
melanocytes from? So that's something that I try to impress upon my residents. I'll say, hey, what's the most feared complication here? And if you're in a room of 100 people, 98 of them are going to put their hands up and say hyperpigmentation. And yes,
Hmm.
that's a nuisance, but that's a treatable nuisance, right? Hypopigmentation, depigmentation, which I have seen in patients coming to me from places that just use the wrong device or the wrong settings.
Yeah, you cannot. I mean, you can't repigment the skin. If it scars down, you kill those melanocytes. They're gone forever. They're not coming back. So I like that. For hyperpigmentation, let's just peel this a little bit more. Do you pre-treat with like a hydroquinone and post-treat? What's your like? Give us the goods. Give us like the inside scoop of
Yeah.
your protocol.
So it really depends on the treatment that I'm offering. For instance, microneedling, just regular microneedling. I'm more focused on ramping up collagen production. So I'm more likely to do retinoids, vitamin C, peptides in the pre-treatment phase because I want to get everything I can get out of it. Studies show that you can get up to a 400% increase in collagen with 4 microneedling sessions. And so I want to add, what do you need in order to build that collagen, right? So, people
What's
go,
the depth? Sorry, what's the depth you're using?
so I tend to use, depending on where I am on the face, anywhere between zero point 0.5 and 1.5. So in thicker tissue, if I'm on the cheeks, for instance, I'll go to 1.5, between 1 and 1.5. But if somebody has a really thin forehead, right, I don't want to be too deep there. It is unnecessary. Or the bridge of the nose, you can get a lot
You're
of,
gonna hit bone.
yeah. So you have to be more shallow there. I tend to be a little bit more shallow in those that have crepey skin under the eye. But rejuvenating the under eye area, we really do need to build up collagen. And so there are a couple different ways I approach the under eye aside from, filler. We've really moved away from doing a lot of tear trough filler because most people actually just need to rejuvenate the skin there. And they need something to kind of hold that area in place. They need more collagen, more elastin. So yeah, so I would say between zero point 0.5 and 1.5. If I'm treating actual scars, I may go a little bit deeper, but I find that just based on, again, the anatomy of the skin, you're going to hit the dermis, between 1 and 1.5. So no need to be super deep unless you're treating scars.
I love that conversation. So just staying with microneedling, are you using PRP exosomes? Or are you just doing microneedling alone? I think maybe it's now over a decade ago. I'm really dating myself. I wrote a chapter in a book about or an article about microneedling alone versus with PRP. Now I'm mostly using PRP and exosomes, one or the other. What do you do? What's the inside baseball for
I'm
you?
with you. So I started off just doing microneedling, and then it got to the point when we started adding PRP that I refused to do it without PRP. Patients were just
Agreed
healing
100%.
so much faster. So I just took away the option. So I'm like, yeah, you're getting microneedling with PRP. It's just what you're getting. So I agree with you. And I do exosomes as well. It really depends on the patient's, what they can afford, because obviously exosomes are a little bit more expensive. But I definitely say almost always microneedling with PRP and then exosomes. And I'm seeing the difference in the healing time as well as the results. So yes, I'm a huge believer in that as an additive.
And which exosomes are you using, if I
So
can ask you?
yeah, so I use mostly Benev exosomes for my treatment.
I love it. I think, I mean, I've been using exosomes and microneedling probably for 5, maybe 7 years, and I've gone from human exosomes, and then, the FDA came down, and a lot of us were using a lot of human tissue. Now I've switched to plant-based probably for maybe 2.5 years. I use a product called Derive, but, whatever is better in your hands is what you use.
Hmm.
And, I know Benev works well as also. But I think that every patient that I've treated, I've never had a patient who didn't come back and get another treatment. And
Right.
that's exactly what I tell folks.
Yeah.
Like once you see how your skin glows after
Yes.
that procedure, people are always going to come back.
And you can use it for so many different indications. I use it for patients with recalcitrant melasma. It even regular microneedling works for it. I use it for patients obviously just looking for rejuvenation. But I really do. There was a trend on social media where there were a few people saying, "Oh yeah, microneedling doesn't work," and I'm like, this is false. I don't know what type of microneedling device you're using or what your technique is, but the price point for microneedling and the efficacy that we get, I just think it's a huge opportunity miss if patients are being steered away from microneedling.
I 100% agree. And if you're a young dermatologist just starting out, you can get a really nice microneedling pen for very little money. You know, it's not a huge investment. It's not a laser that's going to cost you
Right.
$150,000 that you may or may not even be using,
Right.
you know, and
It's
it's,
on my
you know,
list of
the
things. I often have residents who are just, or, have just graduated and they're asking me, what do I
should
need
be
to
the
start
first
my
thing they buy.
practice? And I'm like, you
Yep.
need to get some generic chemical peels, you need to get a microneedling device, and you need to get something for PRP or PRFM.
Yeah, I love it for skin, for scars, for rejuvenation, melasma, hair loss. I use it
Yeah,
all the time, you know, to deliver exosomes. And look, there are studies that show that microneedling itself induces anagen
absolutely. I
hair
presented that
follicles.
data at
So
AAD, just microneedling
there
alone.
you go, hot off the press. So I think it's a great treatment. I want to, you said something about peptides. I want to talk about peptides for just a minute because I tried using peptides in patients with androgenic alopecia. I spent thousands and thousands of dollars. My patients spent thousands of dollars. And I think what we got out of it was bupkis. You know, I just feel like everyone thinks peptides are like the next best thing, and they may be the next best thing, but there's
Can I
so
ask,
little
are you talking
data.
about
Yeah, tell me.
topical
Injectable,
peptides or
injectable
injectable? Okay,
peptides. I
yeah.
was injecting peptides, and I won't say which ones because we're going to get hate mail because people, it's like a religion for a lot of folks with peptides. But I think that there still needs to be more studies. And, you know, my question always is like, how do I know that the lab where I'm buying these peptides, that they're actual peptides and whatever it is that I'm injecting? It's not just saline,
Yeah, yeah, that's
you know?
always the question. And it's sort of in this gray area when it comes to anything systemic. So whether it's peptides, hydrolyzed collagen, I get these questions all the time. And the issue I think is that your body is going to, even antioxidants, your body is going to prioritize distributing them in a way that your most vulnerable spots or organs are going to consume them, right? So let's face it, we live in a lot of pollution. We're not sleeping as much as we should. We're doing a lot of things to our body. So probably a very small amount is actually your hair is not a priority to your body. Right? So
That's why
probably only
telogen effluvium
right,
happens.
a
Yeah.
small amount. It's like, oh, we're stressed. Oh, hair's got to go, right? That's the last thing your body is thinking about. So trying to, and I actually love injectable peptides, but trying to use that to grow hair, you're going to have to put it on locally, right? You're going to have to use peptides in a topical serum of some sort because if you
Well, I was
consume them,
injecting into the scalp. I was injecting along with PRP and doing exosomes, and I just didn't see any extra umph
yeah, from it.
from the peptides.
It's hard though because we have, minoxidil, right? That works extremely well. So everybody is going to compare
People
everything
use
to
it,
that.
yes.
Yeah.
Yeah.
So, it's hard. I would say from a skin perspective, I've seen great results. I don't use peptides, injectable peptides for hair. I'm with you. The hair is a mini organ though, right? So I think it requires a lot. So it can't just be one thing, or it can't even be a small group of things. And even when it comes to something as old as androgenic alopecia, I just think that there's so much more to the story that we haven't uncovered. So I'm not surprised that you didn't see those results. I would say I'm mostly using them for the skin, and I've seen great results.
Maybe I give it another shot. You convinced me. Maybe I look up to see which one seems the most credible, and give it another go.
Give it another 6 months to see
Six
what.
months minimum.
Yeah,
That's right. That 3 to 6 month hair cycle. It really takes. You got to go in faith alone
yeah,
for a
you
while before
do,
you actually see
you
something.
do.
You really do. All right, so let's look at the video you brought because I know that you want to show off some of your favorite one of your favorite devices, I should say. So if we can roll that clip, and if maybe for those of you that are listening, we are going to show a video of Cheri doing a procedure. Maybe you can kind of talk through it
Sure.
and sort of tell us what is important, what are you focusing on, how do you select it, All the good stuff. Give us all the good stuff that goes with it.
Yeah, so this is one of my favorite devices. So this is a radio frequency microneedling device. This is Silphrone X. And again, we know that the FDA came out with sort of this warning about radio frequency microneedling devices, but that's because we have so much unsupervised use of these devices, and people really don't understand it's powerful technology. And when you don't understand it, you're going to get yourself into trouble. So the reason I like this particular device is because for a lot of radio frequency microneedling devices, they have a continuous wave, meaning that every time you fire, what you're getting is sort of a long pulse duration of that heat being distributed through the and in between the microneedles. And so for tightening or scarring, that's great. You're gonna, get more coagulation, you're gonna get more protein remodeling. However, when we're treating things like rosacea, we're treating things like melasma, we're treating things like acne, this device offers a different wavelength, and that is a pulse wave. So we're getting short bursts. Think about a laser with like, a picosecond technology, right? So you're getting short bursts of that heat. And so again, here I'm treating some hyperpigmentation, a little overlap with melasma, with some maturational hyperpigmentation here. And the melanocytes are responding to those short little bursts of heat, but also what else responds to it are your blood vessels, right? So if we think about the pathology of melasma, we know they're ectatic vessels, melanocytes, but there are also senescent fibroblasts involved. And so the pulse duration is able to target the melanocytes, the blood vessels, and the fibroblasts, but do that without producing this sort of buildup of heat that can trigger the melanocytes to fire and create more pigmentation. And so I have used this in post-inflammatory hyperpigmentation. We have a study that we're concluding right now for melasma in patients with skin type 4 through 6. It's a safety study to show that it doesn't worsen melasma, but people were really concerned. They're like, okay, you're using a energy-based device, you're using heat to treat melasma. But again, it's because we're superficial, we're not deep in the skin, right? So when I'm treating melasma, especially like epidermal component, I'm usually 0.5 to 0.8 millimeters into the skin. And then I'm usually 0.8, a little deeper there when I'm doing like a dermal component. But we're doing these short bursts of heat to target, again, the melanocytes, the senescent fibroblasts, but also those ectatic blood vessels that are present, and rejuvenating the skin. And rejuvenating the skin is such an important component when you're treating melasma, because we know that when you look at it under the microscope, it looks like solar elastosis, it looks like aged skin. And this is one of the reasons why melasma just comes back with a vengeance, is because we're often using just bleaching agents to get rid of the pigmentation, but we're not repairing the skin. And that is why I use this device. I use it alone. I have used it in conjunction with topicals. Thiamidol is a topical that I use a lot for my patients now with pigmentary disorders. Also still use some hydroquinone in addition to some of the other cosmeceuticals that target pigmentation. But love this device. Downtime is like minimal. I use exosomes and PRP following this device, and I've gotten some really good results.
You heard it here first. This is like a master class in melasma, pathophysiology, pathogenesis, treatment algorithms. I mean, that was really wow. So I think I learned a lot from just hearing you talk through this laser. So just as a follow up, tell me about doing PRP exosomes. Are you putting it on the same day, right after the procedure? Are you injecting it? Are you doing mesotherapy? How are you applying them?
Yeah, so I've done sort of all of those things. Definitely when it comes to PRP, we put it on just as a topical after, same thing with exosomes, but I have injected PRP into the skin. Again, the idea here with melasma is that it's not just a pigmentary disorder. This is skin that needs to be rejuvenated. And so PRP can help to rejuvenate the skin, and we are able to inject that because it is autologous, right? And so we're not going to get into any issues with injecting PRP. I use PRFM, which is a fibrin matrix, supposed to help keep the platelets there longer, to release growth factors longer. So that's why I use that specific device. And I've even injected TXA, sterile TXA, into melasma before for patients. Those are patients who aren't candidates or not good candidates for oral TXA. We've done topical TXA just following microneedling. I haven't seen the results I was hoping to see with just a topical TXA after microneedling, radiofrequency microneedling, or microneedling alone. So I kind of got away from doing that. But certainly PRP and exosomes, we've seen really good results.
Sounds like something we all of us should be trying for our patients with melasma, and I love the approach of treating these epidermal and dermal components because I think a lot of us forget that it's not just on the surface of the skin, and obviously prevention with hormone, making sure that the hormones are where they need to be for female patients especially and male patients, and then sun protection is obviously key afterwards because those patients just they tend to be like a revolving door. They keep
Absolutely.
coming back. They go away for the summer and they come back with more melasma when they in the fall. So Cherie, I'm going to put you in the hot seat right now. Okay,
Okay.
I'm going to ask you a series of questions. It's going to be quick, and I want to know exactly what comes to mind first.
Okay.
Okay, forget all your
I'm
conflicts of
ready.
interest. Just tell me what your thoughts are.
I'm ready.
Favored botulinum toxin.
Botox.
We're together on that one. Okay, good. Any reasons for that?
I just think it's been the most reliable. And I do use other ones, but the other botulinum toxins, I may like them more for a certain area, right? Okay, I like this for the glabella, but I didn't like this in the forehead, or I like this for, the crow's feet, but I didn't like it for the glabella. But when it comes to Botox, I know I could just pick up that bottle and use it everywhere. And so that's why I put it as number one.
It's the OG botulinum toxin. It's the one I learned first, and
Yeah.
that's the one I'm with you. I stick with it. Okay, next question. Favorite filler?
Oh, Restylane. I really love Restylane fillers. I specifically love Contour, and I really, really love Define. I want to throw one more in there though, and that's the RHA Redensity. I think that's one of the best fillers. I can put that in superficial light. It really was a game changer and really converted me because most of the time I'm using Restylane fillers, but I have to put a nod for Redensity. It's amazing.
If you could only use one, like I'm more of a Juvederm person. Although if you look at my filler closet, it's half Juvederm, half Restylane. But I learned with Juvederm first, so that's kind of what I go to. If somebody said to you, look, you can only have one filler for the rest of your career, which one could you live with and that you could use anywhere?
Contour.
Contour. That's very interesting. I like it. For me, it's either Restylane L or Ultra because I feel like those have so much versatility. But I like Contour. I think it's a great product.
It's just so
Um,
smooth. It's so smooth. I don't feel like I can do Restylane L in some places that I feel like I can do contour. So I'm a big contour. I put contour in lips. Okay. It's not on
you're
label,
putting it
but
in
I
lips.
have put it
I
in
love it.
lips. I
I
have
love
put
it.
it everywhere. I really do love it.
So you're a contour
I
person. I
am.
got it. I like it. I like it. If you're a Restylane contour, call her. You got a spokesperson right there. All right, next one. Favorite laser.
Um, oh, why'd you do this to me? Favorite
You can only
laser.
pick one.
I'm gonna go with, oh, this is hard. This is really, really hard. And when we say laser, are we talking about all energy-based devices, or are you going to ask me for radio?
Energy-based
Okay.
devices.
Okay. I'm gonna have to go with, and this may just be a right now thing, but I probably am gonna have to go with my Airlays Neo.
Okay. Tell folks why.
So this is a 650 microsecond laser, and I would put it at the top for a number of reasons. one, I can treat pigmentation. I have treated bruising, blood vessels with it. I've treated hair with it. So I think just based on its versatility, and it's so compact, I can move that thing around from room to room, from office to office. And there's not a single patient I can't use that device on. So yeah, I would have to put that at the top right now. Yeah.
See, I have something similar for me. It's the Cutera XLV with laser genesis because you got 532 for red and then
Yeah.
1064 for brown or spots. And I think that's probably the one that I use the most in my office because it's so versatile, and I think it's probably for a similar reason
Yeah.
you picked the Aerolase
Yeah.
laser. I like it.
I love a lot of devices. Sorry if I didn't name your device. You know I love your device too, but for its versatility and its, how compact it is. So, yeah.
It's okay if you don't name everybody. You can have opinions. It's fine. You can't. No one can be all things to all people.
Right.
Um, so next one is your favorite procedure.
Oh, you know what? This is pretty easy. And maybe because I trained in Florida, I love a good like skin cancer excision, just like a basic, you got a squame I need to cut out melanoma. It's just like I can just put on my music, I just get in my zone, stitch it up real nice. I just love it. It's just, it's not like a cyst where this thing may rupture and just get messy
Go
and
all over the
smelly,
place. Yep.
right? I really, and again, it may be because I trained in Florida, so I can't even tell you how many just skin cancer excisions that I've done, but I
What's your
think it's,
skin to skin average?
say that again.
What's the skin to skin average in an excision? Let's say you have a, I don't know, 8 millimeter basal cell in an arm. What's your skin to skin?
So
10
I would
minutes,
say,
five
and I,
minutes,
I
30
think I
minutes.
have timed it. I can get it done in like 12 minutes. Yeah. It's like
I
soup, soup,
like it.
soup, soup, soup. But again, I trained in Florida and my co-resident and I would, we did excellent jobs, but we go in the room and then we come out. It was like, ha, beat you.
Who's first, huh?
Yeah. And I think I
If you're a
thrive on
patient, don't listen to this.
no, but the outcomes are so good, right? Like we're so my teachers, faculty were so particular. Oh my God, no. We are really, really good at it. And I would definitely brag about that. And we thrive on making the scar as small as possible. I remember I had this one patient, this is when I was an attending here, and she came back and she's like, yeah, my doctor can't believe it was a melanoma. They want you to send the report, the results. And so I sent it to them and they're like, did you take enough margins? I'm like, yeah, we took enough margins. I always take, tumor with margins first. And then I go back and do my repair. But, I can make it small. Lipomas, people are like, this big. My scar is like this big. I thrive on that. So I would
Good
say
for
just,
you.
yeah.
You're really passionate about excisions. I don't think I've ever seen anyone talk so passionately about an excision with intermediate or complex
No,
closure. I
it's
love
kind
it.
of crazy, but yeah, I love it.
This is the last one, okay? What aesthetic condition is your favorite one to treat?
Um, I would say acne scarring for sure. Just the emotional toll that acne has. And then to have the nerve to leave all of these marks and scars behind, right? It's like you finally get your
Insult to
acne.
injury.
It's horrible. And when you can improve that for patients, it just makes all the difference in the world. So we've been doing a ton for whatever reason, just lately, we've been doing a ton of acne scarring procedures in our patients, and they are so happy. I mean, we've really transformed lives. Yeah, so I would say that's probably the most gratifying aesthetic procedure.
That's a big one. I mean, so many patients have scarring, pigmentation, erythema,
Hmm.
as sequelae of acne. I think that's a great one. Well, you're off the hot seat. I love your answers. One more question and then we're done, okay? The last question is if you could look into the future, let's say in the next 10, 15, 20 years, where do you think aesthetics are going? What do you think the future holds for us as practitioners and for our patients?
I think everything is shifting to preventative. There's a shift away from, thank goodness, this sort of overfilling and these really
The Fifth
outrageous.
Avenue look.
Yeah, we're shifting away from that, thank goodness. But in doing that, people are more focused on longevity, and they're more focused on prevention. And so again, that's where you get peptides and all of those things that come into play, because they want to delay the signs of aging. And so we're just going to see more, I think, more science and more data around peptides, around regenerative medicine, around epigenetics. So I think that's where we're going. And, people will hopefully look young. I think about Death Becomes Her, that movie, right? Everybody wants to look like Isabella Rossellini, but she's like
Yep.
170 years old.
Night.
She still
Yeah.
looks great. Yeah,
I love that because that's truly anti-aging. We've been saying that we're doing anti-aging medicine forever, but really, for the longest time, we've been doing corrective medicine.
correct.
And
Yes.
anti-aging truly is prevention. It's making more collagen as you age so your skin doesn't sag, not waiting for the lines and wrinkles to set in by doing what kids are calling pre-tox.
Right.
And really getting away from overfilling and really changing somebody's look, but just making them look the best they can for where they are in life. I think
Yeah.
that's okay.
Face
And I love
maxing,
that.
face maxing, skin
Is
maxing.
that what the kids are
You
calling it
you
now?
heard you
Face
heard it
maxing?
here. You heard it here with the skin maxing.
I just heard about slugging the other day, which is
Oh,
smearing
Gary,
Vaseline on your.
you are
Yeah.
so behind.
I'm behind. I'm behind. I'm behind. What can I tell you? That's okay. Cherie, you're an amazing guest. Thank you so much for taking the time and really appreciate your expertise. And I hope that you'll come back and if you have something else to talk to us about or something else to share, you really are. It was really terrific to have you on. So thank
Thank
you.
you. I appreciate it. Thank you so much.
And thank you everybody for tuning in. Remember, all the episodes of Conversations and Aesthetics can be found on dermsquare.com. Until next time, thank you so much.